session is Technological Advancement in Public Health. Technology in healthcare has moved from hospital services automation to online appointment with doctors to reduce crowding at government hospitals. What all can be done in terms of technology to ensure healthcare reaches more people with ease? For this, we have Dr. Harsh Mahajan, CEO, Mahajan Imaging, Dr. Sanjiv Kumar, Executive Director, National Health Systems Resources Center, Ministry of Health and Family Welfare, Government of India, Mr. Arvind Sivaramakrishnan, CIO, Apollo Hospitals, Mr. Rajat Ghai, Head, Government Business and PPP, GE Healthcare South Asia. The moderator for the panel is Mr. Anjan Bose, Secretary General, Healthcare Federation of India. Over to you, Mr. Bose. Thank you.
So we have, firstly, this panel was to start at 7 p.m. and now it is 8:15. So first announcement is that instead of 45 minutes or so, we'll have it for half an hour. And it's Saturday night after all. And we'll have 10 minutes, max 10 minutes for question answer. One important reason is that, Harsh, after this, there is a panel on IVF with all our eminent ladies.
Glamorous.
I wanted to be politically correct. We'll finish sharp at 8:55. Technology is such a subject, I don't know, I think Shahid gave this to me, possibly because I come from healthcare technology background. It's such a subject that I think between five of us, we can speak for the whole day. But to make it crisp, I'll kick it off by quoting something which, you know, all of us have memories for some small things we carry throughout our life. So when as a young engineer, I went to US for the first time, and like many people, I went to Disneyland and got very impressed. Disneyland always impresses you over the decades. And you know, when I came out of a side gate, there was a placard which said, "This work shall remain incomplete as long as human imagination lasts." This work shall remain incomplete as long as human imagination lasts. To me, the journey of healthcare technology, Harsh, last 30, 40 years has been, it's, you know, there is some new invention, you think this is the ultimate, that's the best, and then as Larry Page said, this is not the best, it's just a starting point for the next best. So with that, I will kick it off by maybe asking you, Harsh, the topic here is technology and its impact on public health, okay? We don't have to stick to public health because that gets you know, often interpreted in various ways. I'll just leave it to you now to give your interpretation. As India's and Asia's one of the best imaging professional, and with some of the best centers that we have in our country, how have you seen this evolving with respect to its impact on public health or health in general, you know? So would you like to take a shot?
I think when we define public health, I mean, if we put it very in a layman language,
sure,
it's health of the public.
Right.
And that includes hospitals, it includes the smaller, you know, PHCs, CHCs, district hospitals. And I think since the last 32 years or so that I've been in radiology, there's been a sea change. And this technological advance has been brought about or has been possible because of development of IT. In fact, IT was the leader, and healthcare advancement and technology advancement, you know, newer machines, all were made possible because you had the computing power to be able to actually, you know, squeeze everything out of the medical technology.
Sure.
And right from, I mean, when I started at PGI Chandigarh, we had X-rays, and we also had cath labs at that time.
We thought X-rays was the ultimate at that time.
It was the ultimate. And of course, in '84, ultrasound was there, though even PGI Chandigarh in 1984 did not have an ultrasound. It came in 1985.
Imagine, yeah.
And CT scans were there, but there was one CT scan outside. if you remember Mr. R.K. Gupta,
Yes, yes.
who set up nearly
Yes.
70 centers across the country,
Yes.
he had one outside. And really, there was nothing else.
Sure, absolutely.
To today, where, you know, even Delhi would have probably 300, 350
Sure.
CT scanners,
Sure.
over 100 MRI scanners. And it wasn't just technology for technology's sake.
Sure.
Actually, every new technology which came, and ultrasound
Sure.
has been a game changer,
Sure.
you know, in this country. It's an inexpensive technology, costs very less for the
Safer.
patient, safer, and we have radiologists doing it
Sure.
in India, unlike, you know, sonographers,
Sure.
technologists doing it in the US. It has made a sea change in early diagnosis, in correct diagnosis,
Sure.
in finding out the etiology of disease and disease characterization, and hence has changed how we are treating illness.
Sure.
And I think all of this has been for a reason. If
Sure.
today there has been such a glut of machines, as one would say, but still there are many, many, many more that are to come. As
Absolutely.
we realize, in 39 hospitals of the
Sure.
Delhi government, there's one MRI scanner.
Absolutely. Absolutely.
And so we still have a long way to
Sure,
go.
absolutely. So I think I'll take from there, we still have a long way to go. And as you mentioned, you use the words information technology. You brought me down memory lane when Professor Hounsfield, whose discovery and use of computing started CT scanner, then it was possible to have a slice imaging of the body. And we thought, wow, that's the end. And then someone had the smart idea that human body was 90 whatever percentage water, and water is magnetic. So why not use that property to, for imaging the human body? And that's how MRI came. So I'll go to
Just an aside on
sure,
this.
sure.
You talked about the first EMI scanner.
Right.
When they made the prototype machine,
Right.
For one slice, to have it be reconstructed, they would go home in the evening,
Right.
come back in the morning,
Right.
and yet that one slice would not
Absolutely.
be, visible. And today, head to toe, and this was a 10 millimeter thick slice.
Sure.
Today, head to toe with 0.5 millimeter
Correct.
slices. I mean, in the blink of an eye, it takes
Absolutely.
only about 10 seconds to do it,
Sure.
and already the images are coming the moment. So it's
Absolutely.
that's what has made the difference.
So, next to space and defense, I think technology and electronics perhaps have contributed most to healthcare. And obviously, these have had impacts on, like Dr. Mahajan said, on the early diagnosis and consequent treatment. I'll go to information technology, Arvind. The age of information technology, we were there for 6 hours together in the workshop of the Health Ministry today. One aspect is the way imaging and diagnostics and therapy and everything, even in pathology, Dr. Lal is there, the way things have evolved. I think the advent of, information technology, the advent of new information technology techniques like, we used to use a pager here even 12 years back, and today we are one of the top mobile countries. So as CIO of India's and Asia's one of the top healthcare delivery group, the way you are describing today in the morning in the presentation, I was very impressed. The way you talked about finally we look for predictive. Would you like to give our esteemed audience an idea or share with us what is your journey directly, the impact of information technology on healthcare, and how is Apollo as a hospital utilizing that to improve healthcare, both public and any which way?
Anjan, in terms of getting information technology into healthcare, really the power of that is to ensure that the medical profession is kept to the science of it and the art of it. And there is a huge amount of other activities that needs to happen, and use the power of information technology to enable them give the best care. So it's basically data that transforms into information. that gives extremely powerful insights that works back into the entire cycle of care to ensure that you have a complete continuum of care, a speed to diagnosis, as well as once there is diagnosis, a speed to wellness. Once there is wellness, keeping the patient in that system of wellness and not bringing him back into illness. That's basically the use of information technology. And when you look at it, whether it is going to be the deployment of IoT devices that monitor healthcare, or whether it is going to be powerful big data analytics, all of them are going to contribute to that state of information, so that you move from a state of reporting to prescriptive. And when you say prescriptive, so that you have a huge population. When you have huge population, there are trends that can be analyzed. That doesn't mean that we are trying to put everything through a computer and remove the use of a doctor. It's basically increasing the speed. Given the volume of people that we need to do, how can we ensure that it is kept accurate? Using information technology, how do we minimize errors? You know, Dr. Lal spoke about the two patients whose barcode was exchanged. How do we ensure that? Because those do contribute, and I'm sure in their family for about 6 to 8 hours, they must have been hugely tensed. So you're looking at information technology trying to bring maximum safety to patients and help the doctors in delivering care as fast as possible.
Yeah, I was just going to ask you, say I'm a patient, and you are doing all these things using information technology. What do I expect as a patient when I walk into Apollo? You know, if information technology was not there to the extent that it is today, as say 10 years back, what was there, and today when I walk in as a patient, what do I expect?
See, as
some specific examples in the day of the life of a patient in Apollo Hospital.
See, in a day of life of a patient, how do you see that? And this is kind of what I tell my team. As long as doctors and nurses, in a lighter vein, don't talk about IT, that means that we're doing a fabulously good job.
Right, absolutely.
But in a patient, the patient's entry is smooth. The patient's appointment is smooth. You manage his wait time with the doctor's office efficiently. You manage his doctor experience efficiently.
Right.
The post-doctor experience, if it's got to be diagnostics or filling up prescription, that's managed efficiently. His repeat appointments in the event of hospitalization. Now to the organization, I'm talking to the operational staff, I'm not talking doctors. If this entire operational queue is managed efficiently, you create so much of bandwidth where additional service can be done for more patients. This is what we're talking about, reducing the wastage, increasing efficiency. So the patient is going to see efficient systems. The patient is going to see much more effective handling of healthcare.
So should I expect a reduction of cost without compromising the quality?
Over time, definitely we should be seeing a reduction in cost. Yes, all services do cost certain amount of money. This is not about making anything less cost or something. But yes, over time, when waste reduces, definitely we are going to see reduction in cost. Or if there is no reduction in cost, there is going to be increase in efficiency. That means speed. So your average length of stay should reduce. Your effective cost will reduce. That's
so then, from the cost, from Arvind, let me go to Dr. Sanjiv Kumar from the Ministry of Health and Family Welfare, because cost reduction is very closely connected with this public health stuff. And, possibly in the last at least half a decade, if you ask me to name 2 words that being in healthcare sector we see most often, one is affordability and the other, anyone wants to take?
Access.
Yeah, and access. So, it's easier said than done, like Sachin, affordability and access, high quality, affordability, accessibility and quality. There is a balancing game involved in this. So what is your perspective as a representative, senior representative from the ministry? Would you like to enlighten us a little bit? How have you seen things evolve what would you like the, say, for example, private sector to do in terms of PPP or any other area? So please give a short perspective of the ministry.
Technology is already there in health. If you look at various health indicators, when India got freedom, an average Indian was living for 32 years, and today it is 68 years. Look at child mortality rate. In
32?
around 1947, early 50s, it was 160. It came down to, it has gone down to 40. From 90 to, the pace of decline has accelerated. Why? Because of technology. New vaccines, new interventions which are life-saving, cost-effective. So one point on that. Second, I heard in the previous session that non-communicable diseases are emerging. No, they have emerged already. If you look at 98 lakh Indians who die today, 58 lakh, 60% of die because of non-communicable diseases. 27 lakh die of cardiovascular diseases including hypertension, maternal, child health, communicable diseases, nutrition, all put together equal to this 27 lakh. So, and technology is going to help us in monitoring blood pressure, monitoring diabetes, connecting the record. If I go to one health facility and I go to another one, my record is there, and we heard from the minister we are moving in that direction. Third point, which the minister said very rightly, 12%, around 11.4 lakh of them die because of injuries. So emergency medicine has to be there, and how can we link to that? Coming to some examples of how technology is helping the specific question you asked. My colleague Mohammed Amil, raise your hand, is in the audience. NHSRC has developed what we call is an anytime medicine. Many of the primary healthcare centers don't have doctor. They were not there 40 years back 45 years back when I joined medical school. Dr. Ramalinga Swami, our director, told me there are no doctors. And today, 45 years later, we are still hearing no doctor. Now cost of medical education has gone so high that probably doctors will not be there in future as well. So this anytime medicine using telephone technology, mobile telephone technology, you have basic 30 medicines provided at sub-center using telephone technology. The ANM is able to connect with a doctor who's sitting 40, 50 or 100 kilometers away. She facilitated the transaction, communication between the patient and the doctor, including some basic examination. And the doctor there sends an SMS message. This SMS message is linked to a machine like you have at the airport for soft drinks and snacks. So he sends a message and medicines are dropped. A&M explains to the patient this medicine twice, this medicine 3 times or 4 times. That is one example. It is being piloted in about 100 centers in 5 states.
No, this is a great example. I'll come back to you. I mean, anytime medicine, even I don't know about others, but I was not aware of this very nice, rather, I would say, you know, the moment we hear technology, often a very complex picture comes to our mind. But technology does not have to be complex. Actually, those technology that are simple to use and cost effective are the best technology, and definitely best technology in healthcare. So I think anytime medicine is one such great example, because the speed with which, the simplicity with which it is delivered, as we can understand, is facilitated by technology. So, you know, let me just go to Rajat now. You come from world's one of the most respected technology organizations.
So I wanted to make one more point. National Health System Resource Center, which I represent here, is a technical support body for Ministry of Health. Ministry of Health is very keen on innovation and scaling up technology. They have set up a system of what is called Health Innovation Portal online. Any technology which is developed can be uploaded. The job of healthcare technology team is to download that, get the basic information which is incomplete. 40 such technologies have been evaluated and 62 are in the pipeline. The government, after this group approves it and finds it is addressing burden of disease, it is replicable, it is cost effective, submits a report to the ministry. Ministry asks all 36 states and union territories, include it in your next, we call it program implementation plan for funding from the center to the state, and you can scale it up in the whole state.
Excellent. So you see, in public health, there is a lot of good impact on technology. I mean, it's really good to sit, all of us, good to see the top private players and a senior official from the government agreeing that technology is good in healthcare. I'll go to Rajat. Coming to a specific question, I mean, you can sort of share with the team what is GE's perspective on technology and how it has evolved. What is ahead of us? But before that, I'll ask you a question which many of us are finding it difficult to get an answer of. Take telemedicine, which is a part of the the whole E and M business, which Arvind was discussed in the ministry workshop also. Why hasn't telemedicine taken off, you think, to the extent that it was hoped to take off a decade back? Any perspective from your side?
Sure. So I would say a couple of points there. I think there is always that bandwidth, the network. So let's say there is an infrastructure aspect to it, which means are there people, is there an adequate infrastructure which is there or not? The second is what's the cost of the data transfer, the viability aspect of it. And the third is the end user, I would say, knowledge, comfort and interface. I would say if I were to kind of pinpoint three big reasons, I'm sure Arvind could kind of elaborate more. That's a subject which he would be far more touched around. But I would say if there are three big reasons where we have struggled, I think it's a great concept. Clearly, if we have to, because top clinicians would always be in tier 1. You would always struggle to have the best of the doctors in tier 3. If you want to get them the access and quality, I would say, inputs, it's a given that it has to be there. But why they would have struggled to my mind is this. But given the whole, I would say, telecom boom, I think 4G of the world coming through, the cost dropping down, I think this is kind of in thing. It's just a matter of few years when it really kind of becomes the big thing. I think to answer to your earlier question in terms of how do we see GE getting technology to address.
You heard Dr. Mahajan, like what next? That's the question.
Yeah. No, absolutely. So in fact, my association with healthcare is so very limited that I really can't go back to 80s and 90s. I have been a capital guy and kind of moved to my healthcare role almost a year back. So what I would rather focus is the recent innovations which I see in my company. And I think it does address, I would say, the three basic mantras, Anjan, which you highlighted, which is affordability, access and quality. And if I were to kind of pick up few examples, and Dr. Mahajan is an end user, I would say silent MR is really one innovation which kind of addresses that. Just for the audience, if you go through a normal MR, the sound of the decibel sound is more like 110 decibels, which is like a noise of a rock concert. It's that noisy.
I'm smiling.
Getting it to a whisper is something which, to my mind, is convenience to the patient.
No, we can all relate to that.
Yeah.
Those who have gone as a patient or relatives, a little kid goes inside an MRI room, and sometimes when there is an integrated place, and when the MR is very close to where you live, then I think it adds to the comfort of the doctors also, right?
Yeah, absolutely.
So that's a great, it sounds so simple, a silent MR. What's the big deal? It's a big deal because it adds to the comfort, it reduces the worry level of the patient and their relatives. So thanks for pointing out this reason. I just want to highlight one of the things out of all the good things that you mentioned. You heard earlier also, at the end of the day, whatever technology may bring, the doctor still the patient still wants to get the touch, feel and care of the doctor. Would you like to comment on that?
No, that's an absolute fact, and even the doctor wants, to test the patient.
Yeah.
But fact of the matter is, I mean, when we talk of telemedicine, we are not really addressing tier 3 cities.
Right.
Those already have doctors there. We are talking really of the periphery, of the rural areas, the primary health centers. The problem there has been of intent,
Right.
more, than
The technology
lack of
inadequacy.
technology or the cost of technology. The
Right.
government was always willing
Sure.
to fund it.
Sure.
We have our satellites
Sure.
up there wanting to help.
Sure.
When you have absenteeism,
Sure.
as was
Minister
said
was, yeah.
just now,
Yeah.
when you don't have the doctor coming to the PHC,
Right.
who is going to ask for the telemedicine
Input.
and then in the medical college where there is that one room dedicated.
Right.
I know in Rashtrapati Bhavan
Right.
there was one
Right.
room dedicated for telemedicine, and the only time probably it worked was when President Kalam came and
Right.
inaugurated it.
For-
So
yeah.
it's also a matter of intent,
yes.
and the person on the ground wanting to utilize that
Sure.
facility.
Absolutely.
In fact, I have suggested over time that this absenteeism can be done away with if you actually start doing this. If you have those cameras focused there, then you know whether the doctor came at 9 and went at 5,
Sure.
or he didn't come at all.
Sure.
But being a state subject makes it even more
Complex.
complex,
Yeah.
because every state does the way it does.
Sure.
And I've actually, said to the health ministry at the center, it seems laws would need to be changed for this, that rather than giving money for a PHC, give them services,
Sure.
give them technology, and there can be a central body actually seeing whether things are going on or not. But it seems that won't happen. There's
Sure.
too much politics.
No, it's in 20, 25 minutes, so many good points have come up. You bring out an excellent point about intent, that you can have all the technology of the world in private and public sector, but unless the intent is there, unless the desire and the ability to use it there, it's like giving, you have a great musical instrument, but the musician is not trained. You can't produce what that musical instrument is capable of
Or
proving.
the musician is absent.
Or the musician is absent, it won't play automatically. It's a very good point. And so I just...
Sir, can I make one?
Yeah, sure, yeah.
Many good things are happening in public health system. Private sector is way ahead in using technology. To give you an example, there is a small state in the northeast called Tripura. Every primary health center is connected for teleophthalmology with Agartala Medical College. There are only 19 ophthalmologists there, and I am told next 2 years, 10 of them are going to retire.
Sure.
They are not going to get more. So, an optometrist is sitting in a PHC, examines the child through various equipment which has been provided, and a faculty member in medical college in Agartala is giving prescription.
Sure.
95% of these cases can be treated at PHC, only 5% need to be referred. It has been scaled up in the whole state. Another example, telepathology in Andhra Pradesh has been, teleradiology has been scaled up in the whole state. Every X-ray machine is connected through a digital decoder, and somebody sitting far away gives opinion. And if they have confusion, second opinion is also taken online. If the two opinions don't agree, then there is a third person who is relatively more
Sure.
senior.
So, Dr.
it's
Kumar,
it is being scaled up in many states.
I think, what these two excellent examples of Tripura and Telangana and Andhra, I think that further corroborate what Dr. Mahajan was saying. If you have to have the necessary and minimum condition for technology to succeed for the good of healthcare is that intent. So I think where there was an intent in like Tripura for the teleophthalmology, it just worked. So Arvind, coming back to you, Apollo started, since you come from the Apollo legacy, 10 years back we had the Apollo Health Highway and stuff like that. And today we also got a number of examples. It's like I'm again reminded of another eminent inventor's quote who said that if I failed 10,000 times, I know that those 10,000 ways couldn't work. This is Thomas Alva Edison. We are all in this lighted situation because of him. And I mean, what a positive in the country.
You're right. We went into information technology right from the beginning. And it has been, I must say, overall if you look at it, it's been a very pleasant outcome. But the journey has been difficult. Why has it been difficult? Because we'll have to work with the technology companies to explain to them the scale and the magnitude that we are doing, which is unprecedented.
Right.
So that's a learning that happens. We have to work with the suppliers who give us the supplies of all from the traditional service industry to the IT industry. Those are aspects. And then definitely the huge issue of change management and adoption and keeping it sustained. So it's just not merely management pressure or tactics of threatening or anything like that. Those are techniques that will always fail. It is ensuring that you explain to them the need, the benefit, the hand holding. Them as in the operational teams, the doctors, and the entire organization that includes the patient, because many a times the patient has to be excluded.
Yeah, so that's the point that I wanted to bring out, excuse me, because I promised to the audience that we'll finish, we'll stop at
we got 10 minutes to go.
But you have, I think, the last sentence had the word which is the most important word in
the center of our
healthcare,
ecosystem.
which is the center of healthcare ecosystem, and that is, Dr. Sanjiv, what is that? Patient, right? So I think we promised with the permission of the panelists to keep it short and crisp and going. I think half an hour is over. We'll take questions for 5 minutes if there are any, and then let the ladies take over for IVF session. Okay? Yeah. Yes, please. First of all, that sounds like Sanjeev's voice.
Yeah.
Just a basic observation. There was an article in WHO Manual of Healthcare, which was about 10 years back, in which the title of the chapter was "To Err is Human."
Right.
To err is human. This is the published thing. Anyone can search it.
Right.
The same thing has been rewritten in New England Journal of Medicine in May 2016, in which it is written, "To err is human, but it's avoidable." The third most leading cause of death in Western countries, including US, published data, is medical errors. 9.5% of all population in US dies because of medical errors, including Canada, including UK and other places. First one being cardiac, second being onco, third being medical errors. And technology is proven to push this below 1% as a statistical chance of a patient dying because of medical errors. So if anything which helps operational team, anything which helps better clinical outcomes, it helps patient survival, decreases hospital-acquired risk of infection, decreases medical errors, and it gives a better support for building management systems. That word is technology. It's good, it works, it should be there.
Excellent. I think that you bring out an excellent point, Sanjiv, that on a lighter vein at this time on Saturday evening, by the way, when you said, did you say New England Journal in the month of May? So I think I thought of Brexit. Somehow it came to my mind, Brexit. Yeah. So when you said to err is human, but it is avoidable, I wish they knew that about Brexit. Anyway, that's something. It is recording. I know, and this is not healthcare related. So I think you bring out an excellent point that medical error is reduced by the use of technology, and medical error is one of the top causes for health hazards, right? So, any other questions?
Yeah, there is a complete business plan which we've made in technology, how it helps, one, in cost saving, two, in increasing revenue in new business ventures. So there's a comprehensive plan which we've made, and in fact, we get a better ROI on using enhanced technology than even in patient care.
Absolutely. So, I mean, if that brings out another point, I think, Sachin, you have started a model which is also a completely innovative model. And what Sanjiv just now said, I will interpret it my own way. Cutting corners necessarily do not help. That's what you are saying. Is there any question? Otherwise, maybe I'll ask. Yeah? Yes, please. Yes, madam. Yeah, can you give a mic? Could you introduce yourself, madam?
I'm Dr. Nalini Mahajan. I'm an IVF specialist.
Okay. Sorry for my ignorance.
No, not at all. So what I wanted to know is that when technology advances so much, for instance, you have digitalized everything and the clarity on the x-rays and everything is so great now, but why is the lower rung kind of things not outdated and removed? Because it is so sad that patient spends money and comes to you with an x-ray plate, you can see nothing on it. So they've wasted that amount of money, and now you're going to tell them, no, this is terrible, please go to this, go to Dr. Mahajan and get a proper thing done. So if it is out, if it's completely removed, as you're doing with all cars and this, this is also removed off, then nobody has the chance to, you know.
I think Dr. Mahajan is an excellent question. I, as a technologist in health, can mention, but I think one of you should take it.
I think there is growing awareness about the fact that we may have outdated technology, and you know, because of the fact that we don't have standards which are recognized, fixed, because of that, this still goes on. Then a lot of this goes on under the head of charitable, you know, where some do definitely do charity, but many may just be charitable in name only and cutting corners. I think legislation is coming in, is already there, and will only get tougher as things go. But there is a lot of, you know, resistance to this, and at times it may also be over the top. We have to look at the reality of our country, the reality of what people can afford to pay, and only then will, over time, things improve. The public-private partnership, which was alluded to earlier, may be a step in that direction. Insurance becoming universal would definitely lead to uplifting of standards, but I mean, generally what we try doing is buying technology which can be modularly upgraded. So you don't need to pick up that machine and throw it out because something new came, but you can keep building on that and be still contemporary. But these are all questions across the world, not only in this country, but here probably the you know, chasm between the best and the lowest is very huge,
very high,
and we need to bridge that.
I think that's an excellent response, Dr. Mahajan. And you know, madam, I come from technology legacy, and 7 to 9 years maximum is the official working lifespan for any even imaging equipment or a patient monitor or whatever. But there are, I won't name the hospitals for being politically correct. You'll be shocked at what kind of hospitals I have seen machines running 14th year of its life or 15th year of its life, sometimes running well. So I think the key word that I picked up from Dr. Mahajan's response was, these have to be mandated through legislation, and they are coming. Okay, I think this panel would like to stick to the timing, and we have 1.5 minutes left for completing our panel discussion as per our promise. So one last question, please, if anybody, last question or comment on medical technology or healthcare. Okay, so I think ET is nodding to me that they appreciate our time management. Thank you very much, fellow panelists. Thank you.
Thank you, gentlemen. Thank you.
Very well. Nicely.
We will straight away move to our next session.